Welcome to the Step 1 primer video on diastolic heart murmurs. I think Sir William Osler once said there are only three certain things in this life: death, taxes, and getting questions about heart murmurs on USMLE Step 1. That's a paraphrase. But be sure to watch this video and the next one on systolic murmurs. Both videos contain audio samples of heart murmurs just like the ones you may hear on your actual Step 1 exam.
Hello everyone, it's time for another 3-question warm-up. Let's get going. First question here, what drug category has each of the following endings? So we have azepam, you got to think about the benzodiazepines. Azole is going to make you think of antifungal drugs. Caine are going to be the local anesthetics. Cyclin are going to make you think of the tetracycline antibiotics. And Navir are the protease inhibitors. Next question, how does hemicolinium inhibit the transport of choline into the nerve terminal? So hemicolinium inhibits the sodium cotransporter, bringing choline and sodium into the cell. Next question, which aortic arch develops into each of the following structures? So we have the third arch, that's going to give rise to the common carotid artery. The fourth on the left gives rise to the aortic arch. The fourth on the right gives rise to the proximal part of the right subclavian, and then the sixth arch gives rise to the proximal part of the pulmonary arteries and the ductus arteriosus. All right, that's it for the warm-up. Let's get to that lecture now.
Over the next two videos, we're going to discuss heart murmurs. Now, heart murmurs are a 5-star topic, very, very high yield. You should expect several questions about heart murmurs. And you're likely to have a couple of questions where they give you some clinical information and then ask you to listen to an audio recording and identify the murmur. And we have some sample murmurs for you to listen to in a little bit, so make sure you're using headphones for this video, especially when we get to those heart sounds. Now, there are three key pieces of information that you need to pay attention to on questions about heart murmurs: the clinical scenario, the location on the chest where the murmur is the loudest, and whether the murmur is systolic or diastolic. So, as we talk about the different valvular lesions that cause murmurs, pay attention to those three key pieces of information. Now, on the audio questions, you're going to see an illustration of the patient's chest, and you can click on different areas of the chest and hear how the murmur sounds at different locations. Then there's a separate window with a computer-animated patient, and you can see the chest rising and falling as the patient breathes, so you can note whether the murmur gets louder during inspiration or whether there's paradoxical splitting of S2 or wide splitting or whatever. But the most important things to focus on, again, are the clinical scenario, the location of the murmur, and whether it's a systolic or a diastolic murmur. So, what do we mean by the location of the murmur on the chest? Well, placing your stethoscope on different areas of the chest allows you to listen to different valves. Now, there are a ton of different mnemonics for these, like all physicians take money or all patients try medication. But whichever mnemonic you use, A is the aortic valve, which is best heard at the right second interspace adjacent to the sternum. P is for the pulmonic valve, which is heard at the left second interspace adjacent to the sternum. T is for the tricuspid valve, which is heard at the left fourth interspace adjacent to the sternum. And then M is for the mitral valve, which is heard at the left fifth interspace, not adjacent to the sternum, but out in the mid-clavicular line, out at the apex of the heart. So you have to know what valve you're listening to when you put your stethoscope on the patient's chest. And before we get into the murmurs themselves, number 4 in the study guide asks about some abnormal heart sounds that can be considered benign when there's no evidence of disease. So there are 4 of these sounds that I want you to know. The first one is a split S1. So if there's no evidence of disease, a split S1 is not problematic. Now, if there's evidence of disease like syncope or poor perfusion or any other evidence of cardiovascular disease, that's a different story. But if there's no disease, you just happen to hear this incidentally, it's not a big deal. The second one is a split S2 on inspiration. The third sound is an S3 heart sound in a patient younger than 40. So if it's an S3 heart sound in a patient older than 40, you need to think about heart failure, maybe from a silent MI, and then some ischemic cardiomyopathy. But an S3 in a patient under 40 is generally going to be benign unless there's some evidence of disease. Then the fourth sound is an early, quiet systolic murmur. An early, quiet systolic murmur is generally not problematic. Now, if it's a holosystolic murmur, or if it's a loud murmur, or if there's evidence of disease, then that's not going to be benign. But if it's early and it's quiet, and there's no evidence of disease, it's not a problem. Now, most of the heart murmurs we're going to talk about are related to valvular heart disease, because if that valve doesn't open completely or doesn't close completely, that's going to cause turbulent flow of the blood across the valve, and that's what makes that murmur sound, turbulent flow. So it can be very helpful to think about when blood is flowing across each valve in relation to the cardiac cycle, because that helps you really understand why certain valve lesions cause systolic murmurs and why other valve lesions cause diastolic murmurs. So what's going on in the heart during diastole? Well, you're filling your ventricles. So which valves are open? Well, the mitral valve and the tricuspid valve should both be open during diastole. So what are your diastolic heart murmurs? Well, if you have stenosis of the mitral valve or stenosis of the tricuspid valve, that's going to produce a murmur during diastole. So the blood moving from the atria to the ventricles can't get through those stenotic, narrowed valves very easily, so there's turbulent flow and a murmur. So those are examples of diastolic murmurs, mitral and tricuspid stenosis. And what are the aortic valve and the pulmonic valve doing during diastole? Well, those valves should be closed, right? So normally there's no blood flowing across the aortic valve or flowing across the pulmonic valve during diastole. But if you have regurgitation of blood through those valves, the valves don't close completely, and that allows some blood to leak back into the ventricles. Again, that would cause a diastolic murmur. So aortic regurgitation and pulmonic regurgitation will also cause diastolic murmurs. So obviously, you need to be able to listen to a murmur and tell if it's systolic or diastolic. When you hear a diastolic murmur, you know it must be one of those four I just mentioned: mitral stenosis, tricuspid stenosis, aortic regurgitation, or pulmonic regurgitation. And then if you hear the diastolic murmur in the mitral position best, you know it's mitral stenosis. Or if you hear that diastolic murmur best at the pulmonic position, you know it's pulmonic regurgitation. Now, what about systolic murmurs? What's going on in systole? Well, the ventricles are contracting during systole. So which valves should be open during ventricular contraction? Well, it's the aortic valve and the pulmonic valve. So stenosis of either of those two valves is going to cause a systolic murmur. And then regurg through the mitral and tricuspid valves can also cause a systolic murmur. So make sure you understand that. Understanding the physiology is much better than merely memorizing it. There are also certain maneuvers that you can have the patient perform that's going to change the murmur. Make the murmur louder, make the murmur softer, make it longer, make it shorter. Now, this stuff can get very confusing, so I want to keep it simple. And again, I want you to try to understand what's going on so you can just reason it out rather than simply memorizing it. So think about how breathing affects the pressures in the heart. During inspiration, when you take a deep breath, you have negative intrathoracic pressure. And that negative intrathoracic pressure pulls blood from the vena cava into the right atrium. So during inspiration, you have more right atrial filling. So which type of murmur do you think is going to be louder with more right atrial filling during inspiration? A tricuspid murmur or a mitral murmur? Tricuspid murmurs in the right side of the heart become louder during inspiration because there's increased blood flow across that tricuspid valve. But with the mitral valve, the opposite is true. Mitral murmurs become louder with expiration because you're filling up the left atrium more. Now, a couple of students have suggested that the I in the word right can remind you that right-sided murmurs are louder during inspiration because inspiration starts with I. And then the E in left can remind you that left-sided heart murmurs are louder during expiration. Another maneuver is hand grip. So you tell the patient to make a tight fist and hold it for 60 seconds. Now, when all those muscles are contracted, they kind of clamp down all around the arteries in the forearm. And that increased tension will increase systemic vascular resistance and increase afterload. And that makes the murmur of mitral regurgitation louder, as we're going to see. Then the Valsalva maneuver, where you have the patient close his mouth or close his glottis and bear down like they're straining to go to the bathroom, that will increase intrathoracic pressure. So basically it does the opposite of inspiration. It reduces venous return to the right side of the heart, and it also reduces systemic blood pressure if you have Valsalva long enough. So Valsalva reduces both preload and afterload, and it makes most heart murmurs quieter. But there's one murmur that gets louder with Valsalva, and that's the murmur of hypertrophic cardiomyopathy. Now, we're going to talk about hypertrophic cardiomyopathy later in the video on cardiomyopathies, but I want you to file that away for now. Valsalva makes most murmurs quieter, but it makes the murmur of hypertrophic cardiomyopathy louder. Now we're finally ready to look at some characteristics of specific murmurs and the conditions that cause them. So we're going to go over the systolic murmurs in the next video and tackle the diastolic murmurs first, starting with aortic regurgitation. Now this is a phonocardiogram of an aortic regurgitation murmur. You've probably seen something like this before. It's a visual representation of what the murmur sounds like. You can see the S1 heart sound, which occurs when the mitral and tricuspid valves close, and you have the S2 heart sound, which is where the aortic and pulmonic valve close. So in this phonocardiogram, you see that aortic regurgitation is causing a murmur during diastole after S2. You can see that the murmur begins immediately after S2. Again, think about what's going on during diastole. The aortic valve should be closed, but in aortic regurgitation, as soon as the ventricles start to relax and the ventricular pressure starts to drop, blood starts flowing backwards from the aorta into the left ventricle across that regurgitant aortic valve, and you're going to start hearing that diastolic murmur immediately. Aortic regurgitation is heard loudest along the left side of the sternum because that regurgitant jet of blood is shooting right down into the left ventricle. Another clinical clue to the diagnosis of aortic regurg is a wide pulse pressure. So instead of a blood pressure of 120/80, you might see 120/40. If you think this through, it makes perfect sense. The left ventricle has contracted and ejected a bunch of blood up into the aorta, and then as the heart relaxes, that blood's going to start flowing back into the left ventricle. Not all the blood, but a lot of it is going to regurgitate back into the ventricle. So as a result, you're going to have a normal systolic blood pressure, but what happens to the diastolic blood pressure? As that blood flows back into the ventricle, the pressure in the aorta drops off rapidly. So the systemic diastolic pressure will be low, and you have a wide pulse pressure. And a couple of exam findings they might give you that are related to that, without actually having to give you the blood pressure readings, are that this wide pulse pressure can make the peripheral pulses feel really strong and bounding, which is sometimes called a water hammer pulse. And you can also see a subtle head bobbing because of that strong arterial pulse. We'll get your echo scheduled right away, Mr. President. Now, what causes aortic regurgitation? Well, it can be due to dilation of the aortic root. So why would the root of the aorta be dilated? Well, one reason is syphilis. Now, we don't see syphilis very often in the U.S. anymore, but tertiary syphilis can cause dilation of the thoracic aorta and aortic regurgitation, and it can also sometimes cause aortic stenosis. Another cause of dilation of the aortic root is Marfan syndrome, which can also result in aortic regurgitation. Another cause of aortic regurg is a bicuspid aortic valve. So instead of having a normal 3-leaflet aortic valve, the patient just has a 2-leaflet valve. That most commonly causes aortic stenosis, as we're going to see later, but it can also cause aortic regurgitation. And the final cause of aortic regurg would be rheumatic fever. Rheumatic fever can cause all sorts of valve lesions. The next diastolic murmur is mitral stenosis. Now, one thing you'll notice about mitral stenosis is that there's a little pause between S2 and the beginning of the murmur. Remember, the murmur of aortic regurgitation started immediately after S2. So, what's different here? S2 happens when the aortic valve and the pulmonic valve close. At that moment, all 4 valves are supposed to be closed. The ventricles are relaxing and the pressure in the ventricles is dropping, but the pressure hasn't dropped enough for the mitral valves to open. So with all 4 valves closed, the volume in the ventricle isn't changing. So this is called the isovolumetric relaxation period. But the important thing is that the valves are closed, including the mitral valve. And if there's no blood flowing across the mitral valve, there's no murmur. So in mitral stenosis, the murmur starts a little bit after S2 because the mitral valve hasn't opened yet. And then when it does open, it's stenotic, it's narrowed, and it has a snap when it opens. So think of it almost like the leaflets are sort of stuck together. And in order to open, it's going to sort of snap open. Even if you don't quite notice that subtle distinction, the other key feature that's going to help you tell mitral stenosis from aortic regurg is the location. We said that aortic regurg is heard along the left border in the sternum, but mitral stenosis is heard at loudest in the mitral position at the apex of the heart. Mitral murmurs are also heard best when the patient's lying in the left lateral decubitus position. So you have the patient roll over on his or her left side, you put the stethoscope on the mitral area, and that murmur may be a little bit easier to hear. Now, what other heart sounds are heard best in the left lateral decubitus position? Well, there's mitral stenosis, we just mentioned. There's also mitral regurgitation, and then a left-sided S3 heart sound or a left-sided S4 heart sound are also best heard in the left lateral decubitus position. Now, the murmur of mitral stenosis is enhanced by expiration and other maneuvers that increase blood return to the left atrium. So again, we're going to see that expiration is going to enhance the mitral murmurs. One other thing to highlight is the S2 heart sound. It can sometimes be tricky to distinguish a split S2 heart sound from a normal S2 heart sound that's followed by the opening snap from mitral stenosis. Well, the opening snap mitral stenosis will have the murmur after it, obviously, But also, splitting of S2 is exacerbated by inspiration. So inspiration makes S2 more split, while the opening snap and murmur of mitral stenosis are enhanced by expiration. So that's a good diagnostic clue. Mitral stenosis is often caused by rheumatic heart disease, and that can lead to scarring of the mitral leaflets. And then chronic mitral stenosis can result in left atrial dilation, which makes sense if you think about it. If you're not able to empty the left atrium because that mitral valve is stenotic and narrowed, there's going to be more blood and more pressure in the left atrium, and over time, that left atrium is going to dilate. And then the last murmur I want to cover in this video is the patent ductus arteriosus, or PDA, which is a non-valvular lesion. Now, these other murmurs so far have been caused by valve problems, but a PDA is a non-valvular murmur. This is a continuous machine-like murmur that's heard throughout both systole and diastole. It kind of sounds like whew, whew, whew. It's continuous. There's always blood flowing through that PDA. Now, how do we keep a PDA open? With prostaglandins. And how do we close it? With NSAIDs, such as indomethacin. That's pretty much it for the diastolic murmurs. Now we're going to cover the systolic murmurs in the next video. But for right now, let's go ahead and take a look at the end of session quiz. First question, which heart valve should blood be flowing through during systole? So during systole, blood should be flowing through the aortic valve and the pulmonic valve. And then during diastole, it's the tricuspid valve and the mitral valve. Next, what are the diastolic murmurs? So there's tricuspid stenosis, which we didn't discuss, mitral stenosis, aortic regurgitation, and pulmonic regurgitation. And the last one, what murmurs are heard best in the left lateral decubitus position? We said it was your mitral murmurs, so both mitral stenosis and mitral regurg, and also left-sided S3 and S4 heart sounds. And then we have one rapid-fire fact for this video. Bounding pulses, head bobbing, and a diastolic murmur, that should make you think about aortic regurgitation. That's it for now. I'll see you next time. Give me the chief of cardiology at Bethesda.